Hey everyone, Dr. Armaghani here to talk to you all today about the Anterior Cervical Diskectomy and Fusion, also known as the ACDF. This is the most common procedure that I perform in the neck and has excellent results. If you have symptoms of pain or numbness and tingling starting around your neck area and going into your shoulder or arm, also known as cervical radiculopathy, this procedure can help make those symptoms better. Today, though, we'll discuss the normal anatomy of the neck, as well as how I perform this procedure step by step. At the end, I'll discuss risks, expected recovery, and post-operative restrictions. If you'd like to move around a little bit, you can click in the description below for timestamps to move around to different portions of this video. And that's going to be the overview for the video today. Let's get started. Okay. Now that we're in, let's discuss the topic for today, the Anterior Cervical Diskectomy and Fusion, also known as the ACDF. Before we get into how to do this procedure, we need to have an understanding of what the normal anatomy looks like. Over here on your left, this is going to be a normal cervical vertebrae, but this is going to be a front view, as if you're looking at it right from your throat. Now, what you'll see here is that up top, this is going to be where your head is, and then your feet are at the bottom. Let's take a look at some of these important anatomic landmarks. The first of these is going to be the vertebral body. You can think of the vertebral body as the building blocks that make up your spinal column. They're stacked up right on top of each other. In between these vertebrae are going to be the discs, which are outlined here in blue. The discs are a rubbery material which act like a cushion in between the vertebrae. This also allows you to have motion and flexibility in your neck. Next, we have the vertebral artery. These are arteries that come off of the main blood vessels in your chest and go through the neck all the way up into your brain. These are important structures for us to know and see if there are any abnormalities in the vertebral arteries prior to a procedure. Lastly, we have our nerve root here outlined in green. What you'll find is that at each disc space in between two vertebrae, you have a nerve root exiting off to the left or to the right. These nerve roots go to specific areas of your arm and can give sensation and muscle strength. Now let's move on to the top view or the cross-section view. So before we were looking at a view from straight on. This time we're looking at you as if we're in cross-section, so if we cut you right in half through a disc space. The first thing you'll want to notice here is the orientation. The back of your neck is going to be up top here, and the front of your neck is in the front. Again, this is a cross-sectional view of you through a disc space. Speaking of the disc is going to be outlined here in blue. The disc is, again, the cushiony material in between two vertebrae. Next, we have the vertebral arteries. We want to know where these are at all times to help prevent any sort of blood vessel injury during surgery. It is very rare that this happens, but we want to be aware of where they are at all times. Next, we have the nerve roots, which I said again, come off in between vertebrae at each area of the cervical spine and go down to specific areas of your arm or upper back. The spinal cord is highlighted here in purple. As you can see, the area where the spinal cord lives is what we call the spinal canal. The spinal canal is bordered by the disc space in the front and then the spinous process and lamina, which is immediately behind it as shown here. Now, when you touch the back of your neck, that very tip of the bone that you feel, that's going to be the very tip of that spinous process. Now let's quickly go through the side view. Orientation again. This is going to be where your brain is and top of your head. This will be down towards where your feet are. The front of your neck is over here on the left, and the back of your skin of the neck is going to be here on the right. The structures that we want to see here are going to be the vertebrae, outlined in purple, with a disc in between each vertebrae. The vertebral artery is highlighted here in black, and at each area in between the vertebrae, there is a nerve root that goes to a specific area of your arm or upper back. Lastly, the spinous process is highlighted in yellow. And again, this is the area or part of the bone that you can feel when you're touching the back of your neck. You're actually touching these tip of the bones here. Now imagine this front view again, but instead we make a cut right down the middle. What will we see? So here's what that side view ends up looking like if we cut you right down the middle. What you'll find is over here towards the left side of the screen is going to be where the front of your neck is. Your throat and esophagus will be in this area. And then the back of your neck will be here. Let's look at some of these structures more closely though in this particular view. The vertebral bodies are highlighted in purple, and as you remember, there is a disc in between each vertebrae, and that's what we're seeing here highlighted in blue. The spinal cord is in green, and lastly, the spinous processes are highlighted here in yellow. This is what the normal cervical vertebrae will look like without any degeneration at all. What you'll find here is you'll have vertebrae right on top of each other with a disc in between. No compression of the spinal cord at all in this particular normal cervical vertebrae that we're looking at. But not everybody has a normal cervical vertebrae. Sometimes people have a degenerative cervical vertebrae. What we see in patients who have a degenerative cervical vertebrae is we see that they have a couple changes down to their body. The first thing that we're able to see different between this degenerative spine and the normal spine is the size of the disc. You can see here that the disc is not as tall as it was in the normal cervical vertebrae. This happens with normal degeneration. However, as the disc degenerates and gets smaller, you start to form bone spurs, which we have highlighted here in purple. Now you can have bone spurs out near the front, and this won't cause any problems because there are no important structures here that can get compressed. However, in the back of the vertebrae, there are important structures here that can get compressed, mainly the spinal cord highlighted here in yellow. The last thing that happens though is you also see some disc bulging, which we have highlighted here in blue. All of this together creates kinking of the spinal cord, which can cause spinal cord dysfunction or nerve compression, which can then cause pain, discomfort, and sensation changes down the arm. Now, what is the goal of doing a procedure like this? Our goal is to try to remake normal anatomy. We need to remove all those degenerative features that we saw previously. We need to remove the bone spurs, we need to remove any disc bulging, and we need to make the disc height what it used to be back when it was normal. And this is what you end up finding following an anterior cervical discectomy and fusion after surgery. What you're able to see here is that there's no more kinking of the spinal cord anymore because all of the disc space has been removed, the disc space height has been restored, and any of the bone spurs that were impinging upon the spinal cord or nerves are non-existent at this point. So how do we perform this procedure? The first step that we do is we take our burr and we identify these bone spurs that are right here on the front of the vertebrae that are going to be highlighted here in blue. We take this high-speed burr and we're able to shave away that anterior part or front part of the bone spurs to make the area where your vertebrae are flat. Let's see how that's done here. So we'll take our burr and we'll remove those anterior bone spurs so it's nice and flat right on the front surface of the vertebrae. That's going to be step one. Following that, we want to place distractor pins into the vertebrae. What these distractor pins do is they try to create space between the vertebrae to try to remake the size of your disc space which it was previously. After we place the distractor pins within the vertebrae, we want to distract them apart, creating more space in the disc space area for us to try to remove that degenerative disc. You can see here that the space is much taller than it was previously just by placing these distractor pins in place. Next, we take an instrument called a curette and we're able to put this within the disc space and help remove some of that disc material initially. This is what it looks like after we removed part of that disc. But now we still have some bone spurs here on the front lip, and those need to be removed with our high-speed burr. So what we'll do is we'll take our high-speed burr and we'll remove those areas that we highlighted previously in blue, as well as some more of the disc in the back. Once that's complete, we still have a little bit of disc left, as well as any compression that could be on the spinal cord. So we take our curette and we take it all the way back to the back of the vertebrae so that we can fully remove that disc material. Once that disc material is removed, there are no more bone spurs in the back and no more disc material left within the disc space to impinge upon the spinal cord or nerves. Once we remove all the compression of the spinal cord and nerves, the spinal cord returns to its normal position. With our decompression complete and no more compression on the spinal cord, we have to do something to fill this space where the disc used to be. We can't just leave it like that. And so what we do is we'll take a small cage that's sized perfectly to fit your anatomy, and we'll insert that cage in between the vertebrae to act as a spacer to hold that space open. Following that, we remove the distractor pins. And once you remove the distractor pins, you'll find that the vertebrae is able to kind of lean back on some of the angulation that we like to have within the cage. That helps bring a good gentle curvature within your cervical spine. Lastly, once this is complete, we'll place plate and screws, which act like an internal cast or splint to hold everything together, while over the course of a year, this vertebrae sends bone signaling cells through the spacer onto the other bone, thereby completing the fusion. So now let's take a look at what it looked like before surgery and now after surgery. Notice how there is no more kinking of the spinal cord and nerves anymore, and you have a nice flat surface where all the bone spurs were removed previously. This is a successful procedure here. Now that we have an idea of what this surgery looks like from beginning to end from the side, what will that look like from the front view? So let's say we're going to be removing this disc. Step one is to do the discectomy, or remove that disc. So let's go ahead and remove that disc all the way back to the spinal cord. This is the step where we use that high-speed burr for, as well as the curette, to completely remove all the disc material so that there's nothing touching the spinal cord and nerves anymore. Next, once we do this, we'll place a cage in that space between the vertebrae to hold it open. Once this is completed, our last step is to place the plate and screws right onto the front of the vertebrae. This locks it in place and again acts as an internal cast or splint to hold everything together as your body goes through the healing process to fuse those two vertebrae over the course of about a year. These are the final views that you'll see, the front view on the left and the side view on the right. You can see that our plate is well positioned right in the middle of these vertebrae, holding them together tightly, and the side view with the cage acting as a spacer between the vertebrae, and there is no spinal cord or nerve compression anymore. What are the risks of this procedure? After surgery, patients do complain of swallowing difficulty for a few weeks. The reason for this is because we have to move your esophagus out of the way for about 30 to 45 minutes per disc that we are doing this procedure on. A small percentage of patients do have long-term problems with swallowing. Only about 4% of the time does this happen. Those patients who tend to have long-term problems with swallowing tend to be older, have problems previously with swallowing, have a number of different discs done at the same time, and those discs are higher up in the neck. If you are going to be one of those patients, we do have an extensive conversation with you about the issues that can come along with difficulty swallowing. The next risk that people talk about is neck pain. Think of it this way. You had a very collapsed disc before surgery, and in the matter of 30 to 45 minutes, we took that disc and we increased your height about 5 to 6 millimeters perhaps. Those ligaments that are in the back of your neck that are holding those vertebrae together are shortened as well. And in the process of 30 to 45 minutes, those ligaments can be stretched now. The stretch of those ligaments can cause a whiplash type pain or a muscle type pain. That generally gets better after a few weeks as those muscles and ligaments tend to loosen up. One of the more long-term risks is that the fusion does not heal. What's the goal of the procedure again? Well, once we put that cage or spacer in between your vertebrae, your body starts going through the healing process where it sends cells from one vertebrae to the other through that cage or spacer. After about a year, bone forms within that cage connecting the two vertebrae, and so your two bones then become one. That completes the fusion. This happens in about 92% of patients who undergo this procedure. However, that does mean that somewhere between 8 to 10% may not heal. Of those 8 to 10% who don't heal after 1 year, only half of them end up having an issue. For those patients, we end up following them long term to see if they may need a revision procedure to make sure that their bones heal. Patients who have more problems healing after surgery tend to be those who have soft bone like osteoporosis, they're on certain medications, or they're smokers. Persistent pain is something that can come up from time to time as well. Think of what we do as spine surgeons. We take pressure off nerves and we help realign bones. Unfortunately, though, we're not able to fix a permanently damaged nerve. Our goal of surgery is to take all the pressure off the nerve, and then that allows time for your body to go through the healing process. Sometimes the body isn't able to get back exactly what it had before. We generally say wait a year to see how you feel, and how you feel at 1 year is going to be how you feel long term. If, let's say, you're 85% improved at 1 year, that would mean to us that you have about 15% permanent nerve damage. What's the recovery like following surgery? I generally do this procedure as an outpatient, meaning you come in and go home the same day. For some patients, I do keep them overnight if I want them to be observed closely. This is decided upon before surgery. Neck pain and swallowing difficulty is going to be something that you experience with this procedure, but it generally gets better after about 3 to 4 weeks. And lastly, nerves take about 1 year to get better, so no snap judgments on surgery. This is going to be a marathon, not a sprint. In the short term, you can have some good days with your arm or some bad days with your arm. The reason why is this. Think about it this way. You've had your nerve compressed for quite a long time. As a result of your nerve being compressed for a very long time, the rest of the muscles in your arm have become hypersensitive because they need to hear as much of the signal as they can from the brain. That signal has been diminished, though, because of the previous compression. Then within about 30 to 45 minutes, we remove all of that compression, and now all the muscles and nerves within the arm are getting normal signals from the brain. That can cause some increased pain in the arm for a short period of time until the nerves are able to re-equilibrate themselves. That takes about a month or so. Full recovery of nerves, though, takes about 1 year. During that time period, though, you're going to have some good days, some bad days, some good weeks, some bad weeks. How you feel at 1 year, though, is going to be how you feel long term. What can I do post-op? For patients that are going home as an outpatient, I usually have a bandage on that has a drain inside the bandage. Once you remove that bandage on the first day after surgery, the drain will come out with it. Once that happens, pat the area where your incision is dry, and then you can place a new bandage over the top of the incision. If you're going home from the hospital, I will do that part for you before you leave. Once this bandage is removed, though, and changed for the first time, you're allowed to shower on the second day after surgery. What I mean by shower is you can remove the bandage that was covering your incision and let soap and water run down your head and neck just as you would if you were normally showering. You will have butterfly strips that are helping to hold the incision intact because all the stitches are on the inside. After about 1 week, those butterfly strips will fall off on their own. If they're not off by a week, you can pull them off yourself. After about a week or so, you don't have to keep wearing a bandage over the incision once you leave the shower. You could leave it open to air after 1 week. For restrictions, I say no bending, twisting, or lifting greater than 20 pounds for a period of 3 months. If you work a sedentary job or a job where you don't have to do much lifting, you can go back to work whenever you feel up to it. If you work more of a physical type job, let us know ahead of time and we can fill out work release forms for you to work lighter duty during this recovery process. After 3 months, you could do what you would like activity-wise. It is okay for you to walk as much as you want. I don't like patients doing much impact activity such as jogging for at least 6 weeks because of the neck pain that you may be experiencing. After 6 weeks, though, you could do any kind of aerobic activity you would like. From a pain management perspective, I don't want you taking any anti-inflammatories for 6 months. The reason being is because anti-inflammatories actually decrease the fusion rate when you are undergoing this procedure. Examples of anti-inflammatories are ibuprofen, Motrin, Aleve, Advil, Mobic, naproxen, or Celebrex. What you can do is you can take 1,000 milligrams of Tylenol 3 times a day. I usually say take it with breakfast, lunch, and dinner. Even though you may think it doesn't do a whole lot for your pain, it does give you a good background amount of pain relief so that you don't have to take as much prescription pain medication or muscle relaxer. Thanks a lot. And there you have it, the anterior cervical discectomy infusion, also known as the ACDF. Hopefully after this video you have a better understanding of the anatomy, step by step how I perform this procedure, as well as what to expect post-operatively. If you're curious about the conditions that can be treated with this procedure, please click the links below to find the educational videos about cervical radiculopathy and cervical myelopathy. To have a consultation with me regarding your spine, you can find our office phone number below, or you can click Book an Appointment above if you're on our website, www.armaghanisspine.com. You can also find me on these other platforms. And if you're viewing this video on YouTube, please comment, hit like, and subscribe to be notified about future educational videos such as these. Take care.